Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, we'll be having a discussion about a very important condition, which had been known as non-alcoholic fatty liver, but is now known as metabolic associated liver disease, I think. Is that correct?
Metabolic dysfunction associated fatty liver disease.
Okay.
And it's metabolic dysfunction associated steatotic liver disease.
But it's a very important condition, and everybody needs to know about it because this is going to be the leading cause of liver failure for millions of people around the world. And we're already in the midst of an epidemic of this condition as a result of our metabolic health. And we already know from recent research that over 70% of Americans are metabolically unhealthy.
Correct.
So we have Dr. Yousef Elyaman here with us. So Dr. Elyaman, can you tell us about yourself, about your background a little bit and what you've been up to?
Yeah, I'm an internist. I'm a pediatrician. I belong to the first graduating class of the Institute for Functional Medicine. I have my own practice here in Ocala, Florida. We have over 7 providers. We have an insurance-based functional medicine practice. We have health coaches. We have actually over 60 employees. I also am a teaching faculty for the Institute for Functional Medicine. So I do various talks across the world, actually, on functional medicine, on getting to the root cause. I live on a horse and cattle ranch in Ocala, Florida. Happily married, got 7 kids, the oldest of 15. So that's about it.
Yeah, that ought to keep anybody busy.
Oh, yeah.
So tell us why fatty liver disease is so important. I tease the audience a little bit already.
Yeah, so you already kind of mentioned it, but if you look at statistics, between 25 and 30% of people have fatty liver disease already. And you think about that means 1 in every 4 people have it. It is not only can fatty liver lead to liver cirrhosis, needing failure, and liver cancer, but the liver is the center of metabolism. All the stuff in functional medicine we're learning about, like methylation issues and elevation of homocysteine, inflammation, oxidative stress. Most of those things are happening at the level of the liver. So when there's a problem with the liver, and the liver isn't functioning properly, it causes other issues. So when they have fatty liver disease, they have a high chance of dying from a stroke or a heart attack. They have a high chance of having high blood pressure just because of what the liver does. So it's I think because it covers most of our, or at least a quarter of our population, plus it leads to all kinds of other issues, we really do want to know about it.
Absolutely. So how do we know if we have fatty liver? How do we know if a patient has fatty liver? I'll give you an example. I just talked to a patient and she had a CT scan of her abdomen and it showed some fatty infiltration of her liver. Now, is that technically fatty liver, or we need additional testing to really nail that down?
Yeah, we may need to do some additional testing. So now it's called MASLD. So the S is kind of pronounced with a Z. So
right. So the condition had been called non-alcoholic fatty liver, and now
yes, now it's called MASLD. And actually, it does sound a little bit cooler. I was very upset when the name changed, and then it changed again because, I created a course on fatty liver. I have over 10 hours of teaching practitioners how to deal with fatty liver, and it wasn't called MASLD. I actually had to change the name of my course and kind of throw in fatty liver and MASLD. But we can. I know you asked a follow-up question, but just
let's talk about the name and why it's changed.
Yeah, so the reason is that when you call something by what it's not, like non-alcoholic, that it kind of doesn't make sense to call it what it's not. It turns out that it did it when the liver when the liver gets inflamed. One of the things that can happen is it can turn to fat. So that's what they'll see when they do a biopsy, and under a microscope, they'll see that the liver is turning to fat. So it was one of the most common causes back then of the liver turning to fat was alcoholism, or not even alcoholism, when certain people, when they drink alcohol, different people have a different threshold, but some people, it might be one drink a day, it would start turning that liver to fat. So they just called it by what it wasn't, the most common cause at the time, non-alcoholic. And then so naming it by what it's not kind of didn't make sense. So now what it is metabolic dysfunction associated, because like you mentioned, metabolic disease, it's associated with metabolic disease, and metabolic disease is like driving this. And then the other part of it is steatotic. So metabolic dysfunction associated. Steatotic is Latin for fat. And what people were saying is that we were being stigmatized, or patients that had this were being stigmatized. Just calling somebody fat or saying that, hey, this is fatty was a little bit of a shaming thing. And also, even though they called it non-alcoholic, people would go home, tell their family, and their family think, oh, you're drinking too much. Even though it's non-alcoholic, they're like, oh, yeah, it is alcoholic. So that's where non-alcoholic metabolic dysfunction associated. Steatotic is the Latin word, and then liver disease. So that's where the name came in. And then back to your case, you were talking about, was it a CAT scan you mentioned?
Yes.
All right. So there's a CAT scan, and the CAT scan shows that somebody has fat in the liver. Well, we know that they have that they have fatty liver infiltrate, but various conditions can cause the liver to turn to fat. And that's why, in order to make that diagnosis, you do have to rule out other conditions.
Now, is there a difference between alcoholic fatty liver and metabolic associated liver? Is there a different mechanism of what's happening? Because my understanding in metabolic associated liver disease is that as a result of having too much glucose in the system, that glucose is converted into triglycerides and then stored in the liver.
Yeah, so it's interesting. There are about like digging in the research, about 10 really common causes of fatty liver disease. And because alcohol can cause the liver to start turning to fat, that's just one of the reasons for it. And because drinking alcohol is pretty common, there's actually there's a version of MASLD called AC, meaning alcoholic associated as well. So alcohol is a toxin, and that toxin is causing the liver to start turning to fat. Now, alcohol will cause your homocysteine, which is that level in the blood. When that's high, that means that you're not doing what we call methylation properly. And methylation is kind of one of the ways that we break down different hormones and we detoxify. So that homocysteine can also go up, which can cause that liver to start getting inflamed and turn to fat. But like you were saying, that one of the primary causes in MASLD, take away the alcohol piece to it, is insulin resistance. But here's what's interesting about the insulin resistance. Insulin resistance, when you start taking lots of sugar and lots of carbohydrates, then the pancreas has to make up for it. It has to do something about it, because we don't want our blood levels to be filled with sugar. So the pancreas creates insulin, and that insulin is going to drive your glucose or your sugar into the cells. Now, what happens is that whenever our body gets too much of a hormone, like it just oversaturated, whether it's testosterone and people are roiding up too much, whether it's estrogen, what happens is the body just can't handle, or the cells can't handle it, so they start to get resistant to where you need more and more insulin for those receptors to work. So now let's go back to MASLD. People will have lots of sugar, and then they keep getting these spikes of insulin, and then they start getting resistant. And that what would happen is now the insulin is not working, and they're needing more and more insulin. That insulin resistance will cause an enzyme called hormone sensitive lipase found in our fat cells to be overactive. And what that does is it starts tearing up fat in the fat cell and sending it to the liver. So now then the liver, it gets overwhelmed with not only what they're eating, but also with all of these fatty acids that are like overwhelming the liver. So then the liver starts like trying to repackage it, and it repackages it in something called VLDL and triglycerides. Now, VLDL is what becomes LDL, which they usually call bad cholesterol, but we know in functional medicine that it's not always bad. You actually need to have LDL, but it makes the really tiny bad cholesterol. And the really tiny bad cholesterol is what ends up causing clogging of the blood vessels or heart disease and a lot of the issues that we see. So from that mechanism, one of the primary mechanisms of MASLD is going to be that insulin resistance. Now you add toxins to the liver, you're kind of pouring more fuel on it, and then that can happen. That can add a little bit more. But what's interesting is those are just parts. There are so many other causes of MASLD, and if we can't just look at people that have fatty liver or MASLD, and we've ruled out, and we can at some point talk about how to rule out other causes to make sure you actually have the diagnosis, because I think that's important. But there's many other things that may be causing MASLD for our patients that we're not picking up on, and we're just saying, oh, just lose weight. Like that's not the answer. Or
so what are so many other causes?
Okay, so one of the other causes is an elevation of uric acid. So uric acid is a particle that's found in the blood, and it is usually associated with gout. So really high amounts of uric acid in some people, because some people it doesn't really cause that. They'll get gout attacks where they get inflamed, painful joints. But that uric acid, if it's elevated, it can actually cause other things. For example, it can cause fatty liver, and it can cause the body to start storing fat. Now, the question is that why do we have this elevation of uric acid? And the answer is, so we think that it has, so traditionally.
So high uric acid is actually a metabolic issue, right?
Exactly. So it's because when we consume large amounts of fructose, correct, which is found in high fructose corn syrup, when it's found, it's also found in fruit juices. Then and actually you can get high uric acid from drinking alcohol. But what happens is that now the body, when it gets too much fructose at one time, then the body has to use ATP to break it down or to process it. And that ATP, the A in the ATP gets broken down and it increases uric acid. And then uric acid makes us start building more fat. It makes the liver not able to break fat down, and it makes our body store more fat.
So it's not a coincidence that fructose, which has a low glycemic index, because it has to go through this circular route through the liver to finally get metabolized, and the exact same pathway is needed to break down alcohol.
Yeah, are you reading my mind or something here? No, not at all. I thought I was the only one that knew this stuff. No, it is not. It is not a coincidence at all.
Okay.
Yeah, no, it is not. It is not a coincidence. It is. And what's happening is this: if you look at the way we would consume fructose in nature, it was kind of there was fiber with it. There were other things, the different colors in the fruits and vegetables, or phytonutrients had different healing properties. But in reality, if you look at our Stone Age ancestors, we had a mechanism to build or to acquire fat. So what would happen is that in springtime, we would get access to fruits. We would eat a whole bunch of fruits because you don't know how long that's going to last. And then those fruits, one of the things that would happen, they would have sugar in them, and sugar can increase insulin and make us gain fat. But then on the other side, the fruits can cause uric acid to go up, and then the uric acid to go up would also then push us to store fat. And then what would happen is that winter would come, and when winter would come, then unfortunately a lot of vegans would change their minds really quickly, and then not. I mean, hey, we're not in the Stone Ages, so you can definitely be vegan and survive. But back then, what would you have access to? Nuts and seeds and meats. And then the nuts and seeds and meats would then push our body into muscle storage and fat burning to make us kind of change our body composition until spring would come again.
Now, why don't bears die from fatty liver?
Oh, because they're too busy sleeping, man. They're not moving around. Bears are that's
right, because bears eat the fruit.
Yes.
Store fat to last through their hibernation, right?
No, absolutely. So actually, this is just a theoretical thing. So I'm sure the audience knows this is for entertainment purposes only, and don't use this and whatever. But so if you think about it, human beings were not supposed to
make sure to check your bear for fatty liver.
Definitely check the bear for fatty liver. No. So humans, we are not supposed to store fat in our liver.
Do you think Bobby Kennedy checked the bear in the back of his car for fatty liver?
I don't think no.
just kidding. Okay.
Yeah, but I don't think it happens in bears. I think it's more of a human thing because we kind of overdo it a little.
Oh,
like
okay.
We didn't really.
Human beings overdo things.
I know it's shocking, but yes, we sometimes some humans, not me. I don't know what I would never ever overdo things, but some humans would overdo things. Yes.
Okay. I'm sorry for messing up your train of thought.
Not at all. I love this. This is how science can be fun. See,
there you go.
Science is fun.
I agree. I love science. So how do we test for fatty liver? How do we analyze people? What are the labs we want to look at? What are the tests we want to run?
Absolutely. So first of all, we got to rule out other causes, right?
Okay.
So how do we rule out other causes? Well, we're gonna get one of the things we look at is a CBC or a blood count. And when you look at that CBC or blood count, you can look at what's called the mean corpuscular volume, or MCV. And if MCV is high, if the number is high, then that means your red blood cells are large. And what can cause your red blood cells to be large? B12 deficiency, folic acid deficiency, and also in some people that drink alcohol can cause that to happen as well, because it poisons it poisons the system and makes your red blood cells larger. So that would be a clue that there's an issue with alcohol, with that there's an alcohol component to it. And that's something you would talk to patients about and see, is this alcoholic fatty liver, or is it MASLD, or is it a combination of both? The other thing that you can see when you're looking at the blood count is you can look at platelets, and your platelets are going, if you're, and there is a test that you can do called a Fib4. And it's really not a test, but what it is a calculation where they look at liver enzymes, your AST, your ALT, your age, and your platelets. And if your platelets are low compared to what they should be based on what your liver enzymes are, then that can tell you that there is some fibrosis happening, meaning that there's a hardening of the liver. Why? Because the liver is one of its functions is it makes a hormone called thrombopoietin. And thrombopoietin's job is to go to the bone to your bone marrow to tell your bone marrow to make platelets to help the blood clot. But if your liver is damaged, it can't make it as well, and then those platelets are going to be lower. The other thing, though, is that it could be a clue to alcohol as well, because alcohol will poison your bone marrow and not allow it to make those platelets. So those are kind of some of those initial clues. So definitely a good history. Find out if they're drinking alcohol. You can do a viral hepatitis panel. And a viral hepatitis panel is to see if they have these chronic viruses that can infect the liver, like hepatitis C, hepatitis B. Those are the common ones. You also can do something called an autoimmune hepatitis panel. And an autoimmune hepatitis panel is looking to see if you have an issue with autoimmune hepatitis. Autoimmune hepatitis is where the body's attacking the liver. It's attacking itself. You can also get, and this is just kind of the initial, we have more of a functional medicine approach. Of course, we're going to look more, but this is the initial test. So you check that autoimmune hepatitis panel, and you can also check something called alpha-1 antitrypsin. Alpha-1 antitrypsin, it's a genetic condition. If you have alpha-1 antitrypsin deficiency, it's a genetic condition, and what happens is they can get problems with their liver and problems with their lung. You can also check an iron panel with ferritin, because if you have iron overload, that can cause the liver to turn to fat. So that's another thing that we would look at. And then you can also check copper levels. And if your copper is, and it's a little confusing, but if your copper is low, it could mean you have high copper, high free copper. So then you would follow up by getting a ceruloplasmin level, which is the carrier molecule for the copper, and a 24-hour urine copper. But bottom line, if you have too much free copper, that also can turn your liver to fat. And that's kind of the workup you do to rule out other causes. And then in the regular CMP, you're going to look at something called an alkaline phosphatase and a bilirubin. And if the alkaline phosphatase is high, then that's kind of a clue that you have another liver issue. You probably get them to a subspecialist. It's not just the typical fatty liver, or now called MASLD.
What does it mean if the alkaline phosphatase is low?
It means that you have a problem with with kind of the bile flow. We call it cholestasis. So the bile ducts are kind of clogging up, and the bile is not flowing properly.
Ah, interesting. Okay. So we're going to do those tests, and then what's the next step if we're suspecting that there might be fatty liver?
Yeah, so nowadays we have readily available this amazing technology called FibroScan technology. And a FibroScan is a ultrasound technology, but it's specified. And what it can do is it can tell me two things. It gives me what's called a CAP score and a fibrosis score. The CAP score is telling me how much fat is in the liver. And you're supposed to have less than 5% fat in your liver. The fibrosis score tells me how much hardening is happening in the liver. And I can take those numbers without a biopsy, because before you had to do a biopsy to know this. That's the exciting piece. With non-invasive tests, no biopsy. And based on that, I can actually tell the patient, your liver is supposed to be less than 5% fat. You're at a 37% fat. We need to get this down. We need to work on your liver. And I'll tell you something. I have not seen people as motivated to make changes with in their life, or in their lifestyle, in their habits, as I haven't seen anything as powerful to make them have them make changes as when you show them that there's something going on with their liver. It's interesting. You're like, oh yeah, your arteries are clogged up. And okay, we'll try to make some changes. You tell them the liver, and for some reason, they pay attention. But the FibroScan is a definite must. And the fibros, if you can, and the FibroScan also gives you a fibrosis, a hardening number, because we want to see, is the liver hardened? There's another blood test. It's kind of a newer test, but it's part of the guidelines that you can look at called an ELF test. ELF. And the ELF test, when that's high, that also can indicate that you have fibrosis or hardening of the liver. Why is that important? Because if you have hardening of the liver, that the step after that, so you go from fatty, you start getting hardening of the liver to liver cirrhosis, and cirrhosis goes to liver failure. And that's why, to be able to pick up on that and to be able to give them a number and to be able to give them some things to do and see that improve is a game changer.
Now, it's interesting that you get fat infiltration that leads to fibrosis. Why is that? How does that result from fatty infiltration?
Yeah, so because the liver gets all jammed up with fat, you can't, and because of the mechanism behind it, because that insulin resistance can also cause some inflammation coming from fat cells, you can get something called oxidative stress. So you can get glycation, where caramelization is happening in the liver, in the body.
Right.
You get oxidative stress. So that's where rusting is happening in the body. So you have those things, you have that process happening, and you have the liver, man, you back that sucker up enough. And then you start getting inflammation. So it gets inflamed, and you start backing that thing up enough, it'll start getting harder, and it'll start getting that fibrosis.
And a similar process happens in the vascular system, in the arteries, and the heart, where you get oxidation and inflammation, and then you get hardening of the arteries, and you get fibrosis of the heart. And interestingly, you can have fatty infiltration of other organs besides the liver, right?
Right. And I'll tell you what's interesting. So I remember when I first started learning about functional medicine. First, I was a skeptic, then I was a fan in awe, right? And I remember hearing people mentioning these pathways, and I'm like, how do they know so much? But it turns out that the body is pretty similar, and there's only a certain amount of ways that the body can go bad, which is why just mentioning the process of fibrosis, you as a functional medicine practitioner can say, yep, that actually happens over here and over here, over here. But yes, to your point, the body has a finite amount of ways that it can go bad. And depending on where that process is happening, that's the disease condition that they'll end up naming it or calling it.
Right. Dr. Mark Houston is fond of saying there's only 3 finite responses: oxidation, inflammation, and immune dysfunction, that can result from an infinite number of causes.
Right. And you can call it 3 or you can call it 10, right? It depends on how you want to break it down and look at it.
Right.
But yes, and Mark Houston is very famous for mentioning, focus on these 3 things. Right.
Yeah. And so a lot of patients probably who have fatty liver may have fatty pancreas or fatty other organs.
Right.
So what do we do when we discover that a patient we're working with has fatty liver?
Right. So I'm gonna wanna now take a deeper dive of their chemistry. Right.
Okay.
So I'm gonna want to get something called the insulin resistance panel, where not only am I looking at those insulin levels, but I'm also looking at, I can get a score, insulin resistance score, and I can see if based on that test, I can see how much insulin resistance they have. I'll tell you,
and you usually get that from Cleveland Heart Lab?
Cleveland Heart, you can get it from Cardio IQ. I'm a independent contractor with Cleveland Heart and Cardio IQ. I actually work with them. It's not released yet, but I gave them a talk on fatty liver recently. So that'll be coming out soon. But yeah, you can get it from them. There's many specialty labs that you can get an insulin resistance score from. You can also, another test, speaking of Cleveland Heart and Cardio IQ, there's a test called small density LDL.
Yeah, we run that all the time, of course. Yeah.
Right. Now, when you look at it from this aspect, insulin resistance causes in the fat cell the hormone sensitive lipase to be overactive. Now you start to get those fatty acids that are released into the bloodstream. Fatty acids going into the bloodstream go into the liver. In the liver has to do something about it. So it repackages it, but it repackages it in VLDL. VLDL can be the triglyceride rich or triglyceride poor. Triglyceride rich VLDL is from that process that's happening because there's all of these fatty acids. So you get triglyceride rich VLDL. And this is why it's important. As the VLDL starts turning into LDL, IDL and LDL, and releasing the triglycerides, if it's triglyceride rich, you get lots of small density LDL, the one we look at as a risk factor for cardiovascular disease. Why is that important? For various reasons, and we can go into it later, but various reasons, your triglycerides could look normal even though you have fatty liver disease. But one of the biggest markers of your fatty liver disease, so if you have fatty liver disease, if you look at this test, if this number goes down, your fatty liver disease is getting better, and that's small density LDL. So I'm going to want to get a small density LDL. I'm going to want to get a uric acid, and I'm not going to go by the lab's definition of high uric acid. The lab basically is looking for what is a risk factor for gout. I'm worried about metabolic disease.
So 5.5?
5.5 or less. Yep, you did it. You did it again. Stop reading my mind.
Sorry.
Absolutely. I go 5.5. In younger people, we actually want younger women. We're thinking 4.5. So I'll look at I check a uric acid every time I do a lipid panel. It's just part of my panel.
Right. Yeah. If you do an advanced lipid profile, which we always do, we always include uric acid.
Perfect. Yeah, we do the same at our office. So then I look at it and I see the uric acid and I'm like, hey, you're taking it. This is too much fructose. You're taking in too much sugar. So, right. We do these tests. We check the iron. We check these things, and then we like checking a homocysteine because if it's high, then they might need some methyl B vitamins. And then based on that, we will put them on some sort of a treatment plan. So so let's start with nutrition.
By the way, I recently had a conversation with Mark Houston, who informed me that your risk of coronary artery disease goes up with a homocysteine level of above 5.
Wow. Well, I shoot for 7 or less because
right. I do too.
But we're in America, man. If I can get you to 7, man.
Well, exactly. It's like trying to get everybody's blood pressure to 110/70. You're not likely to do it.
Yeah, that homocysteine can be an ugly little thing. Like it causes atherosclerosis. In the Bredesen protocol, for those people, like we do the Bredesen protocol in our office when it comes to dementia and working on memory. Yeah. Right, you want that less than 7. So that homocysteine is a important piece.
Yeah. Okay. Go ahead.
So back to yes, weight loss in the beginning. Weight loss should end up lowering fatty liver. Why? Because now your body's metabolizing fat, right? It's breaking it down. But you got to be careful because if somebody loses weight and then they maintain that weight by eating garbage, eventually what happens is the liver will let go of a lot of its fat and the fatty liver will reverse, and then they maintain the weight, but they're doing all of the junk stuff that we really don't want to be doing. Guess what? The liver can refill with fat again at that weight. So that's the thing. They're just like, oh, just lose weight and you're fine. No. So we got to look a little bit deeper than that.
So what you're trying to tell us is if you just eat less junk because you're taking Ozempic, that's not really a good solution.
Right. So less junk because you're taking semaglutide.
Right. Ozempic, in other words, a person who doesn't change their diet.
Ozempic probably has a lot of money to come after me, but I didn't say
Okay. So let's just say somebody who loses weight by taking a GLP-1 agonist without changing their exercise or eating healthier or doing any of those things.
Why don't you just say Ozempic? so absolutely, that's one of the biggest issues. So do we put people on semaglutide? Do we put people on Ozempic? We do, but we're not going to just say take this shot and see you later. We're saying, if I'm putting you on this as a tool, I'm putting them on it as a tool, already planning for when I'm taking you off of it. Because yes, you just eat less junk, then the body will release fat. And when the body starts to release fat, then the liver will release fat. And then you stabilize, you could potentially then refill that liver up again because of the 9 or 10 potential causes of MASLD. So what was I getting to? What we want is not to just say lose weight and that's it. We want to say, well, what type of a food plan? And I like calling diets food plan because this is kind of the what you eat, right? So what kind of a food plan will cause weight loss? A decrease in fatty liver independent of weight loss. And what I mean by that is that they can stay exactly the same weight on a scale, but their fatty liver starts to go down. And that's the modified Mediterranean food plan. And that's in IFM, we call it the cardio metabolic food plan. We have kind of our own version of that.
Right.
Yeah.
And by modified, it's basically a lower glycemic version, correct?
Correct. So that's eating, and that's the thing. They're eating healthy fats. They're consuming olive oil. They're getting all the different vegetables in. They're nuts and seeds. So things that certain conventional literature may not be endorsing, but they're nuts and seeds are high in fat. Well, you know what? They can be healthy if they're not roasted and not salted. Right. But a modified Mediterranean food plan is really nourishing the body, and you can start to see that. The other thing is that if you can get people to exercise, you can actually decrease fat in the liver independent of weight loss. So if I can just get someone to stay exactly the same weight, but do some sort of exercise, cardio does some things, and resistance training does others. Because what happens? You tell people lose weight or you're toast, and then they'll start to lose weight, and then they'll get hungry and they'll gain a little weight, and then they'll start to feel like depressed. So then they're going to eat more, right? And their fatty liver gets worse. And no. So this is not. We meet people where we're at. Everybody's on their own journey. Everybody has their own things. But why don't we try to increase more of these foods? And why don't we add a little bit of a walk to your Doritos? And why don't we also get some resistance training in there? So nutrition is going to be key, because we're looking for not to lose the fat in it and then the fat pops back. We're looking for a long term, and hopefully they will lose fat as well, and their body composition will change.
Right. Resistance training, I think, is crucial for increasing metabolic rate.
It's huge. Yep.
And not to mention preventing loss of muscle and loss of bone as we get older.
Right. Resistance training is every one of our patients should have some sort of a cardio plan, even if it's just walking 20 or 30 minutes a day. How many patients have I taken off so many different medicines just because I can get them to go for a 30-minute walk a day? Right. And then the resistance training, something about stretch, maybe some sort of like stretch and body. I mean, listen, you're a chiropractor, so you won't know about this stuff, but here, let me help you. So I'm like preaching to the guy. I read your mind, didn't I? It was my turn.
So what else can we do to treat these patients? What about, you mentioned diet, you mentioned exercise. What are some of the other lifestyle factors? And let's go into nutraceuticals.
All right, so let's talk about nutraceuticals. Of course, nutraceuticals are not FDA approved to treat any disease, and we're looking at imbalances, right? So from an imbalance point of view, insulin resistance, there's some go-to nutraceuticals. One of them would be berberine. Berberine can help with insulin resistance. Berberine can help kill bad bacteria in the gut. And one of the things that causes fatty liver that we didn't talk about is something called SIBO, small intestinal bacterial overgrowth. And that what happens is that those lipopolysaccharides that are in the gram-negative bacteria that overwhelm the gut can get absorbed and they can cause inflammation in the liver. So berberine is a go-to because it helps with that. Now, one of the tests that we look at is something called GGT.
By the way, I just saw a paper. Berberine has been shown to reduce kidney damage from high uric acid.
Amazing. Amazing.
It's berberine. It's amazing.
It is great stuff. It is definitely the go-to. So the GGT is a marker. We check it usually. What practitioners usually look at GGT for is if it's high, it means that it's your liver enzymes that are elevated are coming from your liver and not from other tissue, or not from or your alkaline phosphatase. If it's high, it's coming from the liver, it's not coming from the bone. But the reality is that if we really look at what GGT is looking at, it's a byproduct of glutathione, our body's most powerful antioxidant or rust buster. And when you see that GGT high, you know there's oxidative stress happening. So by
the way, what number do you like to see for GGT? And why don't you throw in ALT and AST as well? Because
that's important.
Depending upon the lab, the normal range changes. And I'm always trying to explain to patients, forget about the normal range because that's just reflecting the average American.
Right.
What we're shooting for.
The secret to the optimal numbers they can get if they read my book. I'm just kidding. I don't even have a book. All right. So
where's your book?
I want to have a book one day. so no, you make a good point. There were population studies. So let's look at AST and ALT. AST and ALT are traditionally what we call the liver enzymes. For women, you want your ALT to be 25 or less, men 35 or less, not what the lab says. For a GGT, I want to see it less than 35, better than less than 30. So if my GGT, if someone's GGT is in that higher end of normal or high, then I'm going to think they have oxidative stress. So what are our go-to? If they have insulin resistance and oxidative stress, alpha lipoic acid may be helpful, right? Because it helps with glucose and it helps with that. If they have high GGT, you can think about N-acetylcysteine or NAC because that increases glutathione, but that's not fixing the problem, the underlying problem. But I'll tell you, there's a study that was showing that CoQ10, and I like the ubiquinol form, also can help when you have that elevation in GGT.
Interesting. Probably curcumin as well.
Curcumin, like everything you look at, curcumin helps with.
Absolutely. Curcumin.
As a matter of fact, probably this podcast is doing so well because you take a lot of curcumin.
Absolutely. No wonder I'm orange. No. I don't know. Sometimes, no matter how I set up the lighting, I look a little orange or a little pink or something like that. And you never quite figure all that out. But
no, it's the curcumin. You're probably having a lot of carrot juice too.
No carrot juice.
No,
gave up the juice. So what other nutraceuticals are beneficial?
Yeah, so that just you take a look, you see what the imbalance is. So we talked about insulin resistance, we talked about oxidative stress, an elevation in uric acid. So things like I actually work. I'm the medical director for a company called Human N. They're the ones that make Neo 40 Professional and whatnot. And we actually designed a capsule that has 4 ingredients in it that have been found to lower uric acid. One is tart cherry extract, which may help lower it.
Right.
The other one is vitamin C, because vitamin C may lower it. The other one is going to be a green tea extract.
Okay.
And the fourth one, tart cherry, vitamin C. The fourth one is a surprise. Because I can't remember.
Quercetin, maybe.
No, it was Yeah, yeah, it's a surprise.
Okay. That's okay.
This is homework for the audience to look
Okay.
at uric acid balance.
Yeah, we've been using either Uric X from Designs for Health, or a few
Nice.
other professional companies have uric acid products.
So that's kind of for the uric acid.
Okay.
Oh, I'm sorry. The fourth ingredient was quercetin, because quercetin can lower it as well.
Correct.
And quercetin can help with people that have allergies and people that have, so it can help. It's a mast cell stabilizer, and it actually, and people that have issues with kind of like fibro. A lot of times it's a mast cell issue, so it can help with that. So the only reason I'm mentioning these other conditions is because in functional, you can only take so many pills. So what we're looking for is, what other associated conditions do they have? Let's try to find that one supplement that will help with all of those things. So we talked about high homocysteine. So definitely with homocysteine, you're going to look at your methylation, your B vitamins. Certain B vitamins need to be activated to what's called the methylated form. So your B6 to P5P, your B12 to methyl B12, your folate to methylfolate, your riboflavin to riboflavin 5-phosphate. You also, so all those four things, if you can get them in the already activated methylated form, then they may actually help lower homocysteine, and then, or with homocysteine balance. And then then there's something called trimethylglycine or betaine, and that also can lower it. So sometimes we'll do that. Sometimes we'll give taurine. Taurine is a cool one because taurine may help with work on GABA receptors to help people relax a little bit, and taurine may help with regulate heart rhythm as well. And taurine is needed to conjugate bile acids, and one of the imbalances that cause fatty liver, MASLD, is you can have this abnormal bile acid. That's the cool thing about it. It's not just there's one imbalance. Most people, even functional medicine practitioners, they think, oh yeah, fatty liver, it's just like insulin resistance. No, dude, there is like so many different things. Which is why I don't know why the first course I made on my own was fatty liver. I think I started going down that rabbit hole, and then I'm like, no, this is so freaking important. I don't care if the world doesn't know it. I know it.
Probably herbal bitters would be good for bile flow.
Which one? Bitters. Oh yeah, bitters is part of it.
Yeah,
bitters could be part. It can help with bile flow, cleaning out the gut, because what happens is if you have a lot of bad bacteria, you get these secondary bile acids that worsen fatty liver. Things to kind of help the composition. So phosphatidylcholine, I've seen amazing improvements in fatty liver content from putting people on phosphatidylcholine, and there's research to support that. Not as robust as we'd like, but there's research to support it. And part of what it could do is it's changing the composition and helping bile acids have less cholesterol in it.
Right. That's why when I have a patient with fatty liver, I usually use a curcumin that's bound up with phosphatidylcholine.
2 for 1.
Two for one.
Yep. And sometimes we'll end up giving about 1,800 milligrams of phosphatidylcholine divided twice a day, and we see great results. Also, the vitamin E. Everybody's different, but one of the things that happens in fatty liver is that people will start to deplete their vitamin E. They'll also deplete glutathione, and the challenge with vitamin E is that the type of vitamin E that they usually get over the counter is D-alpha tocopherol.
Yes.
So you see, there's studies that show that taking, yes, exactly, write down, throw it down the drain. Don't even give it to your animals. because what happens is that you look at the literature, and what you see is that vitamin E may be amazing, but it also may cause all kinds of problems. And one of the things we think is that because it depends on what type of vitamin E. Your vitamin E, there's an alpha, beta, delta, gamma tocopherol, alpha, beta, delta, and a gamma tocotrienol, 8 forms. And if you start taking that one form, you could block the other 7 from getting in.
Yes. Yeah, so, I'm big on the tocotrienols.
Since you've been reading my mind so much, I need to get you on my podcast, brother. I really do. Yeah, very good, very good. Yeah, so I think those are there's another supplement that I've been a fan of as well, and it's called TUDCA. And
Oh,
TUDCA,
okay.
it's the taurine-bound ursidiol.
Right.
Ursidiol is also could be a supplement, but it also is it also is a prescription that you can get, and there's data that shows it may help with fatty liver. But TUDCA is one step further, and what it really is like doing is it's like if you think of your bile as the oil of your car, it's that treatment to the oil, so it helps improve the quality of the oil, and it may also help. So for my challenging patients, they're going to have I like TUDCA, I like phosphatidylcholine, I like mixed tocopherols and tocotrienols. These are those challenging patients, but I don't think we should throw all of these supplements at people at once. Find out what's the problem, work on nutrition, work on exercise, follow the tests, and then maybe add a little something here and something there. You got to keep it interesting.
You got it. Yeah, it's easy to get excited and overwhelm them with too many supplements at one time.
Right.
Now, me, myself, I take about 30 twice a day.
That's it. That's the problem.
I'm hedging my bets.
You read about it and you're like, man, this is so amazing. I need this. And then you look at, we should probably just show a picture of our supplement cabinet. I have my own supplement cabinet that's mine. And then I have the family supplement cabinet. Like it's nuts. Every once in a while I go into their supplement cabinet. But I try to for patients you between 3 to 5, and then you kind of give them the options. I never give more than 3 supplements at once, or I try not to. Oh, I missed one supplement. So actually, especially one supplement that I like using to rebalance is going to be the omega-3s. So we'll check omega-3 levels, and we try to optimize omega-3s as well.
Yeah, I think a multi omegas, vitamin D with K, probably a probiotic. That's baseline. Right. That's not even going into supplementation. That's just essential.
That's just replacing what we normally would have gotten if we lived in Stone Age times. Right. We would have gotten our we would have got a bunch of greens, right? And when in the spring, we would have gotten our omega-3 composition would have been much better. We would have been getting sunlight, so our D would be we'd get the vitamin D. The greens we would get our vitamin K from. So yeah, it's the processing that's happening. I agree with you. Those are my bare bone baseline as well. This is like just normal. This is just replacing what normally is missing in everybody in our food.
Right. If we were eating fruits and vegetables that were organic, that weren't grown in soil, that was depleted of nutrients and wasn't over farmed, the same foods grown over and over again, stored in frozen containers, shipped long distances to get to the supermarket, and it's not that hard. And you'd need a time machine, because even with all that, it could still be garbage. So you go back in time and then you harvest and then you get back in the time machine. And I mean, that's what we're working towards. But till then, take those supplements. Yeah, I got my time machine in the back.
I'm working. I have a couple of tweaks to make, but I'm not there yet. Yet.
Yeah, what's happened in the experiment so far? You with your friends?
Listen, I can't talk about it. I can't talk about what happens in my backyard. Okay. You want to come over? Come to Ocala.
All right. So, final thoughts about MASLD.
Yeah. Final thoughts. Now that we have, for those functional medicine practitioners, look up the FibroScan and figure out where you can get one. A lot of times you can get it for free at a research center, because they're researching different drugs for fatty liver disease. There is a new drug that was the first FDA approved drug for fatty liver, and it's they have to have fibrosis F2 and F3, and it's called resmetirom. It's what we call a thyroid beta agonist. So if you look at
see something about that,
yeah, it's only $4,000 a month. So here's the thing. So the thyroid hormone there's different receptors throughout the body for the thyroid hormone. You have alpha and you have beta. The alpha is found in the heart, the beta is found in the liver. And then throughout the body, it's different, right? So what this is it's specific for beta. So it doesn't increase the heart rate. So basically what you're doing is trying to give people thyroid hormone without increasing the heart rate. Now, as functional medicine practitioners, we are checking advanced thyroid panels and we are optimizing thyroid. We know, like if you look at the research, low T3 is a risk factor for having fatty liver disease, which is one of the other imbalances that cause fatty liver, which is why I twitch a little when people say, oh, yeah, that's just insulin resistance. No, bud, it could be toxicity and it could be thyroid dysfunction.
You know what? Real quick, could you just go through the 10 different causes of fatty liver? Because we hit some of them, but I don't know if we hit all of them.
Let me try from the top of my head.
Okay.
We did plan for this, right? I think they need to know our planning. I think they need to know how much we planned for this. Like I texted you this morning. We both had like work to do, and then we just jumped on. Right? So,
exactly.
Right. So insulin resistance, uric acid dysregulation, iron overload it can be a cause. A discordance between your omega-3s and your omega-6s can be a cause. Methylation disorders and hyperhomocystinemia. Now, these are parts of the process or causes, but you can also have the inflammation, oxidative stress can cause it as well. A small intestinal bacterial overgrowth or dysbiosis can be a cause of it. And also bile dysregulation, and also certain food intolerances. So like some people, their fatty liver is caused by celiac disease, like a subclinical celiac, then their problem is gluten. I think those are the major ones. Toxicity. So toxicity can be a component, and there's actually a condition called TAFLD, or maybe it'll be called TASLD now with a new name change. And that's basically they are exposed to some sort of toxin. These are the people that don't have the typical like metabolic syndrome factors, but they have fatty liver, and that would be TASLD as well. So I think those are the main causes, and those are the main things that we're going to want to look at. And then based on your patient's individual imbalance, that's what you're going to go after, and that's what you're going to follow up on.
That's great. For fibrotic liver, are there any things that you use? I've used modified citrus pectin.
Right. So, and modified citrus pectin is helpful probably in all stages, because a subclinical cholestasis is part of the issue, and it can help with growing good bacteria. So yes. But I'd say when they have that fibrosis, I'm going to, number one, get their iron levels optimized. Their ferritin, I need less than 150. I'm going to make sure that they don't have, I'm going to say absolutely no alcohol. I'm going to make sure that I'm going to look at like the get homocysteine and all that stuff down. But I like TUDCA. I like mixed tocopherols and tocotrienols 800 and phosphatidylcholine. And that's when we start hitting it really hard.
What about milk thistle, glutathione, NAC? Oh, I think you mentioned NAC.
Yeah, we can use some NAC. I'll tell you, so if they have elevated liver enzymes based on the numbers that we mentioned, not based on what the lab says, then I usually am going to put them on a mix with milk thistle and NAC and just different things that are going. It's all put together in the same supplement, and that's just kind of a base,
like a liver support formula.
Yeah, just a baseline liver support,
right?
And then you start hitting it hard with the one supplement,
right?
Prescriptions.
Cool. Great. So that was incredible. We covered a lot of information in an hour, Doc.
Nice. Yeah, no, and I had a lot of fun with it. So
I did
that's
too.
excellent. That's excellent.
So tell us about your course that you offer.
Yeah, so we have, it's still fairly new. We have the FMP Essentials, Functional Medicine Practitioner Essentials.com. And the first course we launched was the MASLD course, the Reversal of MASLD course. It's over 10 hours, taking a deeper dive in all of these different imbalances and kind of what we just went over, but kind more of a systematic, all right, do these labs. This is why, recommend these things. It kind of goes more in detail and elaborates more on what we talked about. And how do you, and the beautiful thing about it is that once you went through the course, you not only learned how to deal with fatty liver, but you also learned how to deal with diabetes and coronary artery disease and some of because that's the secondary benefit you're going to get is how to deal with these functional medicine balances. So yeah, we would love to have it's one of the things I'm very proud of. Would love to have you there. If you guys want to keep in contact with me social media wise. So across social media, I'm still learning the social media thing, to be honest. I'm not like one day I'm going to be better at it, but across the platforms.
One day you're going to be Mark Hyman.
Yes, I'm not there yet, man. But I'm coming for you, Mark. So I'm to still stay in his shadow, right? So at Dr. Elyaman for myself, at Dr. Elyaman, and then at FMP Essentials HQ for our functional medicine practitioner essentials, and we're right about to launch a mastermind for functional medicine practitioners. There's going to be a free mastermind that everybody can jump in, and we'll have our own platform, social media platform, and then there'll be kind of like paid tiers. So
that's very cool. So how about patients who want to have you help them?
Patients that want to have me help them. Currently, I'm not seeing new patients.
Oh, okay.
Yeah. So if they live in Ocala, if they live in Florida, they can come check out the practice and see one of our providers. And that's Absolute Health. Absolute Health.
Do remote care?
We're not doing remote care. No, there's licensing. You got to get the license throughout.
Okay.
So
cool.
So you stay in California. I will stay in Florida and take care of the people here. We just need the other 48 states covered, and we'll be good.
Okay, sounds good, Doc. Thank you so much.
You're welcome. My pleasure. Thank you for having me.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.